Hello, and welcome to Surgery Squad's Retinal Detachment Surgery. I'm Dr. Jeff, and I will be guiding you through this procedure today. The retina is located in the back of your eye. When we see, light enters the eye. It is focused onto the retina, which acts like the film in a camera, feeding information to the optic nerve, allowing you to see. As you get older, the vitreal fluid, which is the gel in your eye, can contract, pulling the retina away from the eye. This contraction can cause a small tear in the retina, allowing the fluid to seep behind the retina, detaching it from the back of the eye. This can cause loss of vision. A retinal detachment is a very serious ailment that must be dealt with as soon as possible after discovery. Symptoms that you may experience with a detached retina include seeing floaters or frequent flashes of light, shadows appearing in your peripheral or side vision, a gray curtain moving across your field of vision, or a sudden decrease in your vision. Again, if you experience any of these symptoms, contact your eye doctor immediately. Today, we're going to perform a retinal reattachment called a pneumatic retinopesky. The surgery takes about an hour and can be done on an outpatient basis. Our patient today is a 30-year-old man who recently noticed flashes in his vision. His ophthalmologist dilated the eye and detected a retinal tear and a detachment. He recommended immediate surgery to limit additional loss of vision. Let's begin. First, we need to administer a relaxing sedative intravenously. This will make our patient drowsy, but not put him to sleep. Can you place the needle for me? Just prior to surgery, additional drops of anesthetic are applied. We'll use a device called a speculum to hold the eye open wide during the procedure. Place the speculum for me, please. Now that the patient is anesthetized, we insert a syringe into the eye. Now we inject an air bubble into the vitreal fluid. As the bubble expands, it pushes the retina back against the wall of the eye. With the retina back in place, we can now seal the tear using a freezing probe. The probe is touched to the outside of the eye where the tear is. This freezes the tear back in place. It may take several touches depending on the size of the tear. The tear is now repaired. The needle insertion will heal quickly. Can you remove the speculum? Our patient needs someone to drive him home after the surgery, and he shouldn't drive until he regains sight in the eye. We'll prescribe medicated eye drops to use several times each day for a few weeks after the surgery, and he'll need to wear a protective eye shield while sleeping or napping for about a week after surgery. A special pair of post-op sunglasses also need to be worn to protect his eye from sunlight and other bright light as his eye recovers. However, the biggest part of the recovery is head positioning. The bubble floats to the top of the eye, so the head must be positioned to keep the bubble against the detached portion of the eye. This means the patient must keep his head facing down, or the position indicated by his surgeon, for at least a week. Sight returns slowly to the eye over several months as the bubble must dissolve and be replaced by vitreal fluid. However, once the bubble dissolves, vision is usually restored to close to the previous level. You did a great job today, surgeon. While you're here, try one of our other surgeries here at surgerysquad.com.
Welcome to Surgery Squad's virtual tonsillectomy surgery. I'm Dr. Jeff. Today we'll be removing a young man's tonsils. This is a common operation that's performed when a patient suffers from frequent bouts of tonsillitis. It's most often performed on younger patients, but adults can need it as well. The tonsils are located at the back of your throat on either side of the uvula. That's the little punching bag thingy that hangs down in the middle. Tonsils are infection fighters, but occasionally they lose the fight and get infected themselves. They become red and enlarged and can sometimes make it hard to breathe and swallow. Normally we treat this with antibiotics, but when tonsillitis reoccurs frequently, we remove them because the infection can cause more serious damage. Our patient was given a sedative before being brought into the operating room, and the anesthesiologist will help put him completely under. Help me out and place a breathing tube in our patient's nose to assist with breathing while we operate. We need to get our patient's mouth open wide so we have room to work. To do that, we'll use a special mouth gag retractor that opens the mouth, depresses the tongue, and locks into position. Why don't you take a crack at that? Great job. That should give us plenty of room. Now we have to reach in and grab the infected tonsil with the tonsil forceps. We need to pull it to the side to expose the connective tissue. Can you do that for me? Nicely done. With the tonsil extended out, we need to place this electrocautery device at the tonsil's base. The device uses high-frequency current to cut away tissue and seal off the blood vessels at the same time. By removing the tonsils this way, we reduce bleeding and allow the patient to heal faster. Now that the tonsil has been cauterized, we reach in with a tonsil guillotine clamp. The clamp severs the last of the connective tissue and allows us to remove the tonsil from the throat. Clamp the tonsil and pull it out, would you? We'll bring the electrocautery device back in here and apply it to any bleeding areas. Because this part of the throat heals quickly, we won't need any stitches. Now we repeat our steps on the other side of the throat. Extend the other tonsil with the tonsil forceps. Just like the other side, we'll cauterize this tonsil to release it, while keeping And finally, we need to remove the tonsil. And don't forget those bleeders. I'll clean out the mouth with some irrigation and suction, and then we're all done. We'll send our patient to recovery for 8 to 10 hours, and more than likely he'll be able to go home later today. Once he's sent home, our patient will be put on a course of antibiotics. He'll need to keep hydrated with cold water or sports drinks. And if he gets hungry, he can have cool, soft foods like fruit pops, gelatin, sherbet, pudding, and of course, ice cream. Getting a little hungry? Thanks for stopping by SurgerySquad.com. While you're here, check out some of my other spectacular surgeries. They'll always stand the test of time, unlike my hairline.
Welcome to Surgery Squad's virtual abdominal liposuction. I'm Dr. Susie, and I'll be assisting you with this surgery today. Liposuction is a minimally invasive surgical procedure that is used to remove fat deposits from various areas of the body. The areas that liposuction is generally performed are the abdomen, hips, inner and outer thighs, flanks or love handles, and inner arms. Today we'll be using the tumescent technique to remove fat deposits from our patient's abdomen. The word tumescent means swollen and firm, and with this technique we'll be injecting such a large volume of the fluid into the fat deposits that our patient's abdomen literally becomes tumescent. After injecting the fluid, we'll be using a hollow metal tube called a cannula to break up and essentially vacuum fat deposits out of the body. Before we begin, remember that liposuction is not an alternative to diet and exercise. And, unfortunately, not everyone is a good candidate for liposuction. To be a good candidate, one must usually be over 18 years old, in good general health, be within 30% of their ideal weight, and have made an honest attempt at losing weight through dieting and exercise with little success. Luckily, our patient is not only a great candidate for liposuction, but she doesn't smoke, which will greatly speed up the recovery process. Now that we've covered the basics, let's scrub in. The first thing we need to do is mark the target area. This provides our patient and ourselves with a clear idea of where we'll be removing fat deposits. Why don't you give it a shot? That looks great! Now we need to take photos of our patient so she can see the before and after results. Go ahead and take one picture of the front of the patient's abdomen and one picture of the side. Next, we'll have our patient turn to the side so you can take the second picture. Nice composition! Our patient has been prepped and is now in the operating room. The next step is to numb the incision points that we're going to use to extract the fat deposits. Give it a try. With the incision points numbed, we're going to inject the tumescent fluid using an infiltration cannula to anesthetize the target areas and dislodge the fat deposits, making it easier to suck them out. Go ahead and take a stab at it. Excellent job! Now that we've injected the tumescent fluid, let's begin the liposuction. Use the suction cannula to remove the fat deposits from the patient. You're a natural. Have you ever considered a career in the medical field? Now that we've completed the liposuction on our patient, it's time for recovery. We're not going to suture the incisions. Since they were so small, they can heal without sutures. Our patient will need to wear a compression garment for 2 to 6 weeks. This garment holds the tissues together, controls swelling, and provides additional support as her body heals. She should be able to return to normal activity within a few weeks, and there will still be some bruising that should fade within a few days. Any swelling that our patient has may take a little while longer to subside. The final result of the liposuction will be evident in about 1 to 3 months after the surgery, although they will see a noticeable difference within days or weeks. Although the suctioned fat deposits are gone, if the patient does not maintain a proper diet and exercise regimen, the remaining fat deposits could enlarge, creating irregularities in the patient's abdomen. And that's abdominal liposuction. You've done a fantastic job. Why not try your surgical skills in another great surgery here at SurgerySquad.com.